Picture this. You're at dinner, mid-conversation, and you swallow a bite of food and something feels off. There's a lump sitting right at the base of your throat, like a small stone lodged just above your collarbone. You swallow again. Water this time. A big, determined gulp meant to push it down. It doesn't move. You clear your throat. Still there. Somewhere between the second glass of water and the third throat clear, your brain starts quietly running through a list you never asked for. Thyroid, tumor, something growing where it shouldn't be. Here's the strange part, the part almost nobody knows going in. In the overwhelming majority of cases, when a doctor actually looks, there is no lump, no mass, no growth sitting in your throat at all. And yet the feeling is completely real, not imagined, not in your head, in the dismissive way that phrase usually gets used. The actual cause is a muscle about the size of a fingertip, sitting exactly where your throat meets your esophagus, and once you understand what that muscle is doing and why, the sensation stops being a mystery and starts being something you can predict, explain, and calm down. This isn't going to be a video telling you to sip ginger tea and relax, because just relax has never once made a lump in the throat disappear. This is the actual mechanism, the real research behind it, and by the end, you'll know exactly why it shows up worse at night, worse when you're anxious, and almost never while you're distracted and laughing with friends. Doctors actually have a name for this feeling, and the name itself tells a story about how badly it was misunderstood for most of medical history. For decades, it was called Globus hystericus, a term that quietly implied the sensation was a symptom of hysteria, something psychological, something not quite real. That name has been retired. The modern term is Globus Pharyngeus, or simply Globus Sensation, and the shift in language reflects a genuine shift in understanding. Researchers eventually found that globus shows up in men just as often as women, that it has measurable physical contributors, and that dismissing it as purely psychological was not just unkind, it was scientifically incomplete. Ear, nose, and throat specialists now recognize globus as one of the more common reasons people show up in their clinic, and when they pass a small camera through the nose to look directly at the throat, the tissue looks structurally normal the large majority of the time. No growth, no blockage, no obstruction. Which raises the obvious question this whole video is built around. If nothing is physically sitting there, why does it feel so certain, so specific, so exactly like something is stuck? The answer isn't that your brain is inventing a signal from nothing. The answer is that there's a real, physical structure in your throat fully capable of producing exactly this feeling, and almost nobody has heard of it, because nobody teaches you about the muscles you can't consciously control. There's actually an official classification for this today, and it matters because it settles the psychological versus physical debate for good. Globus sensation is formally listed among what gastroenterologists call functional esophageal disorders, catalogued in a framework known as the Rome criteria, now in its fourth major revision. Functional doesn't mean fake. It's the specific medical term for conditions where the structure is intact and looks completely normal on every scan, but the way it's functioning, how it moves, how sensitive it is, how much tension it's holding, has shifted. Irritable bowel syndrome sits in that same broad category, and nobody seriously argues that irritable bowel syndrome is imaginary. Globus belongs on that same list for the same reason. A real problem with function, not structure, described with actual physiological detail instead of a shrug. That structure is called the upper esophageal sphincter, and its main muscle is called the cricopharyngeus. Picture a narrow one-way gate sitting right at the point where your throat ends and your esophagus, the tube leading down to your stomach, begins. This gate has one main job for nearly every second of your life: stay shut. Keep air out of your esophagus so you're not swallowing air with every breath. Keep whatever's in your stomach from creeping back upward into your throat. Because of that job, this muscle sits in a constant low-level clench, the only muscular ring in your entire digestive tract built to be tight by default rather than relaxed by default. Then, roughly once a minute without you noticing, and deliberately whenever you choose to swallow, it does something remarkable. It opens, just long enough, in tight coordination with your tongue and throat muscles, to let saliva or food pass through, and then it slams shut again immediately afterward. You've already done this thousands of times today without a single conscious thought. It's a gate engineered to be sticky shut and momentarily open, over and over, for your entire life. Here's where it gets interesting, and here's the part almost nobody explains properly. In people who experience globus sensation, that gate frequently isn't cycling the way it should. Using thin pressure-sensing instruments passed gently through the nose, researchers studying esophageal motility have found that, in a meaningful subset of people with globus, this muscle sits with elevated resting tension, clenched tighter than it needs to be, even with no food or liquid anywhere nearby. A muscle meant to fully release between swallows instead stays partially braced. The same way your shoulders creep up toward your ears during a stressful phone call without you ever deciding to tense them. And a persistently over-tightened ring of muscle sitting exactly at the base of your throat produces a sensation that is, frankly, almost indistinguishable from something being stuck there. Not because something is stuck, because the gate itself has forgotten how to fully let go. One quick clarification before we go further, because people often push back on this exact part, but I feel it higher up, near my Adam's apple, not lower where you're describing. That's expected, and it doesn't contradict the mechanism at all. The nerves supplying this whole region overlap and converge before they ever reach the brain, a property called referred sensation. The same reason a heart attack can sometimes be felt in the jaw or left arm instead of the chest. Your brain receives a signal from this gate and localizes it somewhere in the general neighborhood of your throat, not with pinpoint precision. So whether you feel the lump higher, lower, or dead center, it's consistent with the same single source. It's also worth knowing this shows up somewhat unevenly across life stages. Clinical reports on globus note, it tends to be reported more by middle-aged and older adults than by the very young, and somewhat more often around and after menopause, plausibly tied to changes in mucosal dryness and sensitivity during that transition, though how much of that is hormonal versus something else is still being worked out. None of that means younger people or men don't get it. Plenty do. It just means the underlying tissue and hormonal environment can shift how sensitive this whole region is to begin with. So why would a muscle that's run on autopilot for your entire life suddenly decide to stay clenched? There are two separate signals feeding into that gate, and most explanations you'll find online only ever mention one of them, and usually the less complete one. The first signal is chemical, and it comes from below, not above. Stomach acid is meant to stay in the stomach, where the lining is built to tolerate it. When acid escapes upward past the valve at the top of the stomach, most people know this as reflux or heartburn, that burning behind the breastbone. But acid doesn't always stop in the middle of your chest. In a meaningful number of people, tiny amounts of acid or digestive enzyme travel all the way up past the esophagus and reach the throat and voice box, territory with none of the acid-resistant lining your stomach has. This pattern is often called laryngopharyngeal reflux, and one of the clinicians most associated with identifying and naming it is Jamie Kaufman, a laryngologist who spent years documenting how this silent version of reflux behaves completely differently from classic heartburn. The word silent matters here. Many people with this kind of reflux never feel any burning at all. No fire in the chest, no obvious warning sign. What they feel instead is frequent throat clearing, a raspy voice in the morning, a cough that won't quit, and yes, a lump sensation. When acid or enzyme touches the sensitive tissue near that upper gate, the body responds with something protective and completely logical. It tightens the gate further, trying to guard the airway from further exposure. It's the same reflex that makes you clench your throat when something goes down the wrong pipe, except here the trigger is invisible and the clench doesn't fully release afterward. Research on esophageal function from physicians such as Peter Karillas at Northwestern, who has spent much of his career studying how the esophagus and its valves behave under reflux, supports the idea that this upper tightening is a genuine physiological guarding response, not an imagined one layered on top of nothing. Here's a detail worth pausing on, because it changes what avoid trigger foods actually means. Certain foods and drinks don't just sit heavy, they chemically relax the lower valve of your stomach, the one that's supposed to keep acid down in the first place. Caffeine, alcohol, mint, and very fatty meals all do this to some degree, loosening that lower gate and making it mechanically easier for acid to travel upward toward the sensitive tissue near your throat. That's not a vague wellness warning. It's a specific mechanical reason those particular things show up so often in reflux advice. But acid isn't the only thing reaching that gate from a direction you wouldn't expect. If you deal with seasonal allergies, chronic sinus congestion, or frequent post-nasal drip, there's a second, entirely separate contributor worth knowing about, one that isn't about muscle tension at all. Mucus draining from your sinuses down the back of your throat can physically coat the area right where that gate sits, producing a sensation that feels remarkably similar to globus but comes from an actual thin film of mucus rather than a clenched muscle. This is why some people notice their lump sensation tracks almost exactly with allergy season, or gets dramatically better on a day they take an antihistamine. It's a completely different mechanism from the ones we just covered, but it lands in the exact same spot, which is part of why globus has historically been so confusing to sort out. If this sounds like you, staying reasonably hydrated through the day and running a humidifier in a bedroom with very dry air are small, mechanism-specific steps, thinning that mucus rather than doing anything at all to the muscle we're about to get into. Now, the second major signal feeding that gate has nothing to do with your stomach or your sinuses at all, and this is where the story stops being purely digestive and starts involving your nervous system directly. That gate is wired into your vagus nerve, the long wandering nerve connecting your brainstem to your throat, heart, lungs, and gut, and acting as a main communication line for your body's stress response. When you're anxious, even mildly, even in a way you're not fully conscious of, your sympathetic nervous system, the fight or flight branch, increases muscle tone broadly across your body. Your jaw clenches, your shoulders rise, and that upper esophageal sphincter, sitting right in the path of that nerve, tightens right along with everything else. This is why so many people notice their lump gets dramatically worse during a tense conversation, before a big presentation, or lying awake at night with racing thoughts, and dramatically better while laughing with friends or absorbed in something engaging. It isn't that anxiety is manufacturing a fake symptom. It's that anxiety produces a real, measurable rise in muscular tension, and this particular muscle happens to sit exactly where you'd feel that tension as a lump. Reflux and stress aren't competing explanations here. In most people who experience globus, they're two separate inputs converging on the same small ring of muscle, one chemical, one neurological, both landing on the same gate. Stress adds one more twist to this that most people never connect to the lump itself: dry mouth. That same sympathetic activation that tightens muscle throughout your body also actively suppresses saliva production, which is exactly why your mouth turns to cotton right before a job interview or a big presentation. Less saliva means less lubrication for every ordinary swallow, so the same background swallowing you do all day, the kind you never notice, suddenly requires slightly more effort to get past an already tighter gate. It's a small effect on its own, but it stacks directly on top of the muscular tightening already happening, which is part of why anxious moments produce such a convincing, very physical lump rather than a vague, fuzzy feeling of unease. If you've ever noticed you also clench your jaw during the day, or wake up with a sore jaw from grinding your teeth overnight, that's worth paying attention to, because it's the same underlying pattern showing up somewhere else. The muscles of your jaw, neck, and throat are all wired into overlapping stress circuitry, and people under sustained tension often tighten several of these areas together without realizing it. A tense jaw and a tense throat gate frequently travel as a pair, which is a genuinely useful clue. If your jaw is sore, your throat gate is very likely tight too, even on days the lump feels mild. Here's the part that turns an occasional, mild sensation into something that can dominate someone's entire day, and it requires understanding what swallowing actually does to an already tense gate. When you feel that lump, the instinctive response is to swallow hard, deliberately, trying to push the sensation down and away. But remember what that gate's job actually is. It's supposed to stay shut, except for the brief instant of a genuine swallow. If you swallow forcefully and repeatedly, testing whether the sensation is still there, you're asking an already over-tightened muscle to open and close again and again in rapid succession outside its normal rhythm. Rather than resolving the tension, this repeated testing keeps the muscle actively engaged, sometimes leaving it more fatigued and irritated than before you started checking. People with globus often swallow far more often than they realize, sometimes dozens of extra times an hour, purely to check whether the feeling has gone away. It rarely has, because the checking itself is part of what's keeping the gate engaged in the first place. And the checking doesn't stop at swallowing. There's a well-documented pattern researchers studying health-related internet use have called cyberchondria, where repeatedly searching your symptoms doesn't settle anxiety the way you'd expect, it escalates it, because each search surfaces a slightly scarier possibility than the last, and the act of searching itself becomes another form of checking. It's the same loop as the test swallow, just running in a browser instead of a throat. Noticing that pattern in yourself, the third search of the night for the same symptom, is worth treating as a signal to close the tab, not open another one. There's a second layer stacked on top of the muscular one, and this is where the story moves from the throat into the brain's relationship with the body more broadly. Humans have a sense most people have never been taught the name of: interoception, your brain's ongoing monitoring of internal signals like heartbeat, breathing, and yes, muscle tension in your throat. Under ordinary circumstances, your brain filters out most interoceptive signals as background noise, the same way you don't notice the feeling of your tongue resting in your mouth until someone mentions it, and suddenly you can't stop noticing it. Once a sensation like globus captures attention, especially paired with worry about what it might mean, the brain's filtering shifts. It starts treating that specific signal as important, worth monitoring closely, and signals that get monitored closely get amplified, not because the underlying physical intensity changed, but because attention itself turns up the volume on bodily sensation. Arthur Barsky, a psychiatric researcher at Harvard who has spent much of his career studying this exact phenomenon, often described as somatic symptom amplification, has documented how anxious attention toward a bodily sensation reliably makes people rate that same sensation as more intense and more alarming, even when the physical input itself hasn't changed at all. Think of it like a smoke detector mounted in your hallway. Most days you don't even hear it, because there's no smoke and it's quietly doing its job. But start worrying it might be broken, walk over, stare at it, and suddenly the smallest click or flicker feels enormous. Your throat's tension signal behaves the same way. Once you start treating it as a threat worth monitoring, your nervous system treats it as a threat worth amplifying. Now let's address the fear sitting underneath almost everyone's version of this story, because it's usually the real reason people end up frightened at 2 a.m. searching their symptoms. The fear is rarely, "My muscle is tight." It's, "What if it's my thyroid?" Here's the anatomy that actually matters. Your thyroid gland sits low in your neck, just in front of your windpipe, well below your voice box, nowhere near the upper gate we've been discussing. Thyroid nodules are common, and the overwhelming majority found on scans are entirely benign and produce no symptoms whatsoever, discovered incidentally rather than through any lump sensation. For a thyroid problem to actually cause difficulty swallowing or a sensation of pressure, the gland typically has to enlarge substantially, to a degree that's usually visible or easily felt from the outside of the neck, and it tends to come with other findings a doctor can check for directly. In other words, the organ people fear most almost never behaves like classic globus at all. It's simply the scariest word available, so it's the one anxiety reaches for first. This is also exactly why globus sensation frightens people so disproportionately relative to the actual risk involved. When specialists examine patients reporting a persistent lump feeling, structural problems are found only in a small minority of cases. The vast majority of throats examined for globus look entirely unremarkable. That's genuinely reassuring, and it's worth being precise about, because precision matters more here than blanket reassurance. Globus sensation has a specific clinical signature doctors are trained to recognize. It tends to feel better, not worse, while you're actually eating or drinking, and worse while swallowing your own saliva between meals. That pattern, better with food, worse with empty swallows, is actually a hallmark of globus rather than a red flag. What genuinely warrants a prompt doctor's visit, and what looks nothing like ordinary globus, is real difficulty getting solid food or liquid down, meaning food seems to catch or requires noticeable effort, unintentional weight loss, pain specifically with swallowing, a lump you can actually feel with your fingers from outside your neck, or a voice change that doesn't resolve after a couple of weeks. Those symptoms point towards something structural and deserve timely medical evaluation. Ordinary globus, the sensation this video has been describing, notably spares your actual ability to eat. Doctors actually keep these apart with separate vocabulary for exactly this reason. Globus describes a sensation with no real obstruction, while true difficulty swallowing has its own term, dysphagia, reserved for cases where food or liquid genuinely struggles to pass. Knowing which word actually applies to you is often the fastest way to tell which category you're dealing with. If you do go see a doctor about this, and for a first occurrence you should, here's roughly what that visit tends to look like, so it stops feeling like an unknown. It typically starts with a direct look. A thin, flexible camera passed through the nose to view the throat and voice box, which is quick and far less unpleasant than it sounds. If that looks normal, which it usually does, and the pattern matches classic globus, most clinicians won't escalate further right away. If there's any doubt, or if swallowing itself seems affected, the next step is often a barium swallow, where you drink a chalky liquid that shows up on X-ray, letting a radiologist watch exactly how and where food travels down. In persistent or unclear cases, some clinicians add monitoring, a thin sensor left in place for a day that directly measures how often acid is reaching the throat, turning maybe it's reflux into an actual number. Walking through this isn't meant to alarm you into booking every test available. It's that the workup is quick, well-established, and built specifically to rule out the rare structural cause while confirming the far more common functional one. Worth knowing too, for most people globus doesn't behave like a life sentence. Clinicians following patients over time have generally found that a large share see the sensation ease or resolve within weeks to months, often right alongside whatever triggered it settling down, a stretch of high stress passing, a reflux flare getting brought under control, allergy season ending. It can return during some future stretch of stress or reflux, since the same gate is still there and still capable of tightening again, but it can come back is a very different sentence than it never leaves, and for most people it genuinely is the former. There's one more piece that ties several of these threads together, and it explains a pattern almost everyone with globus has noticed but never had explained: why it's so often worse at night and first thing in the morning. Two things happen simultaneously while you sleep, and both make the sensation worse. First, saliva production drops sharply overnight, and saliva is one of your throat's natural defenses against acid, since it's mildly alkaline and normally helps neutralize and wash away anything that creeps upward. With less saliva overnight, any acid that does escape lingers longer against sensitive throat tissue. Second, lying flat removes gravity as an ally. While you're upright during the day, gravity helps keep stomach contents where they belong. Lying down for 7 or 8 hours removes that help entirely, making it mechanically easier for reflux to travel further up the esophagus and reach the throat. Put those two facts together, less saliva to clear it, no gravity to prevent it, and you get exactly the pattern so many people report. A lump that's mild during the day, worse by evening, and often most noticeable of all right after waking up, before you've eaten or had anything to drink. It isn't your imagination doing something worse at night. It's chemistry and physics doing something worse at night, landing on a gate that was probably already a little too tense to begin with. So knowing all of that, what do you actually do with it? There are a few specific, targeted actions worth trying, each one aimed directly at a mechanism just explained, not generic advice pulled from nowhere. First, if reflux is even a mild possibility, and given how common the silent version is even without classic heartburn, avoid lying down for roughly 2 to 3 hours after your last meal of the day, and take a second look at whether that last meal tends to be large, fatty, or heavy on caffeine or alcohol, given the specific way those relax the lower valve we talked about. Some people also find real benefit from slightly elevating the head of the bed, using gravity through the night, the same way it already helps during the day, instead of working against it. This also explains something that puzzles a lot of people who try the most obvious fix first: acid-reducing medication. Because reflux is only one of the 2 tracks feeding this gate. Trials of standard reflux medication for globus have shown mixed results in the clinical literature, helping meaningfully in some patients and doing almost nothing in others. That's not the medication failing, it's a sign of which track is actually driving things for that particular person. If tension from stress is the dominant input, no amount of acid suppression will loosen a gate that's being tightened by your nervous system instead of your stomach, which is exactly why the breathing and checking behavior pieces matter just as much as the dietary ones, not as a backup plan, but because they're targeting the other half of the same mechanism. Second, target the muscle directly, not by trying to force it to relax through willpower, which doesn't work on muscles you don't consciously control, but by activating the nervous system pathway that naturally lowers muscle tone. Slow, deliberate breathing, with exhales longer than inhales, engages your parasympathetic nervous system, the counterpart to the fight-or-flight response. And that same vagal pathway that tightens your throat under stress is equally capable of loosening it under calm. A few minutes of slow breathing, when you notice the sensation building, isn't a vague wellness suggestion. It's a direct attempt to shift which half of your nervous system is currently talking to that gate. A simple version many people find workable. Breathe in gently through the nose for about 4 counts. Then breathe out slowly through the mouth for 6 to 8 counts, repeated for 2 or 3 minutes whenever the sensation starts building. Some speech-language pathologists who specialize in voice and swallowing disorders also offer manual therapy, gentle external massage of the neck and throat muscles, specifically aimed at this same over-tightened muscle group, and it's worth asking a doctor about if the sensation is frequent and disruptive. Third, and this one runs against every instinct you have, stop checking. Every deliberate hard swallow meant to test whether the lump is still there is, as explained earlier, additional unnecessary work for an already fatigued muscle, and additional attention fed into a sensation that gets louder the more closely it's monitored. When you notice the urge to test swallow, try instead to simply continue whatever you were doing, a conversation, a task, anything pulling attention outward. This isn't about ignoring your body. It's about not feeding a feedback loop that runs specifically on the kind of repeated checking that feels like it should help, but consistently makes things worse. Fourth, know the actual warning signs so you can stop worrying about the wrong ones entirely. Real difficulty getting solid food down, pain specifically during swallowing, unexplained weight loss, or a lump you can physically feel from outside your neck are the signals worth bringing to a doctor promptly. Everything else, the sensation that comes and goes, feels worse when you're anxious or tired, improves the moment you're actually eating, and has already been checked once by a doctor who found nothing structurally wrong, fits the well-documented pattern of Globus Sensation, a real physical mechanism involving a small, overworked muscle, not a hidden danger quietly growing in the dark. So go back to that dinner table for a second, the moment this all started. The lump is still there, let's say, right as you swallow, mid-conversation. Except now you know something almost nobody else at that table knows. You know there's a small ring of muscle sitting exactly where your throat becomes your esophagus, built to stay clenched almost all day, every day, and that right now it's likely getting 2 signals at once, some trace of reflux irritating the tissue nearby, some trace of stress tightening it further, both landing on a gate that's simply doing its job a little too enthusiastically. You know that testing it with another hard swallow will very likely make it feel more present, not less. And you know the antidote isn't panic, isn't another frantic search through your symptoms late at night. It's breath, patience, and letting your attention drift back to the conversation in front of you. There's something almost strangely comforting in that. The body isn't malfunctioning in some mysterious, unknowable way. It's a muscle doing exactly what muscles do when they're asked to hold tension for too long, in a place we happen to notice more than almost anywhere else. There's something worth sitting with, too, in how long this exact sensation went misunderstood, filed for generations under a name that blamed the person feeling it rather than explaining it. It took real physiology, a small pressure sensor threaded gently through the nose, careful researchers willing to measure instead of assume, to turn a dismissed complaint into an actual, traceable mechanism. That's usually how understanding works. Not one dramatic discovery, but a slow, patient replacement of judgment with measurement. Maybe the real lesson here isn't just about a lump in the throat at all. Maybe it's a reminder that so many of the sensations that frighten us most aren't signs of something breaking. They're signs of something working a little too hard, quietly asking for exactly the kind of attention we usually save for everything except ourselves.